or her talk, and if there is time remaining, we'll take a couple of questions. For the most part, I'd like you to hold your questions for the more lengthy panel discussion at the end of each session. Now it's my pleasure to welcome back again to this course Dr. Rachel Ashby. She is the director of the third-party reproduction program as part of our IVF program at Brigham and Women's Hospital. Her topic this morning is the modern infertility evaluation. Dr. Ashby.
Thank you, Mark, and thank you so much for inviting me to give this talk today. I enjoy every year talking about infertility and the infertility evaluation, and I think especially for general OBGYNs, this is hopefully a very helpful talk for you. So what I hope that you take from this talk is the following. I'm hoping that you will be able to better educate your patients regarding the related declines in fertility from aging. Kind of how do we talk to our patients about getting pregnant naturally, and what are the best elements for them to understand regarding appropriate timing and lifestyle issues? How do we know as a generalist when to initiate the evaluation for infertility and when do we refer? Finally, what are some of the counseling points for women considering fertility preservation, which I think is really a new and interesting area of medicine that we're seeing more and more. One of my colleagues in a lecture to follow will talk in even greater detail about fertility preservation. And then what is the initial evaluation? Include things such as ovarian fertility preservation. And then what is the initial evaluation? Include things such as ovarian and how to counsel patients about what their probability of pregnancy is on a month-to-month basis and throughout the year. So this was a great study done by Zinnemann looking at 200 couples who were attempting pregnancy just being followed by urine and blood LH and HCG monitoring, to the extent that they were able to see what the fecundability was by month. And you can see within the first 6 months, generally patients were getting pregnant to the realm of 20 to 30% per cycle. And by the end of 1 year, approximately 82% of patients were pregnant. So when we evaluate, it's generally in women who are 35 or younger after 12 months of unprotected and frequent intercourse. We evaluate in women greater than 35 after 6 months of attempts. And for women who are greater than 40, we generally recommend an evaluation from the beginning. We evaluate sooner with any evidence that infertility may be present from the standpoint of menstrual dysfunction. Many of my patients will come to me and say, we've been trying for a year, but I've only had 3 spontaneous periods in that year. This is somebody who can be really evaluated quite quickly. Anybody with a history of chemotherapy, radiation in their past, history of endometriosis, a pelvic infection, or surgery that may be indicative of pelvic adhesive disease or anything that may, influence fertility, I would evaluate these people immediately. In men who have sexual dysfunction, any history of testicular trauma, infection, surgery, if they've had a history of chemotherapy or radiation, or history of subfertility in a previous relationship would be evaluated immediately. So one of the things that I think is an important dialogue to have with our patients is how do we try to get pregnant naturally? What does that look like? And so for many patients, and we'll talk a lot about some of the effects of aging on fertility, but it's trying to conceive before the age of 35. I see this interestingly, a phenomenon where couples are in long-term committed relationships and they know theoretically that they want to have children, but truly have this idea in mind of kind of the perfect timing. And I think for many of us, we recognize there's probably no perfect time. So I talk to these patients a lot about some of the changes in aging of their eggs and of their chances of pregnancy. So if they are able to try to conceive before 35, that is ideal. We talk about how to get pregnant as far as cycle management. And we talk about the fact that getting pregnant 2 days before, the day before, and the day of ovulation are ideal. I encourage my patients really just to look at their cycle from the standpoint of tracking it with calendar. And there are many great apps now that patients use. Really just having intercourse every other day over the time frame in which they're ovulating is ideal. I don't necessarily advocate that they use over-the-counter ovulation predictor kits early. Lifestyle issues, tobacco and alcohol. And I think interestingly, especially in the age of COVID where alcohol intake has increased, this is something we talk about and we'll mention. Weight management. We see a really significant variable with weight and outcomes from fertility and from assisted reproductive technologies that I'll review. And also stress and excessive exercise. We do see a group of women that can develop hypothalamic amenorrhea associated with excessive exercise and sometimes low weight that can influence fertility quite a bit. So another great classic slide from Minkin in 1986. This was looking at multiple populations unfettered by contraception. So the Mennonites in the 1920s, et cetera, where you could really look at the birth and death records of this closed population and see what the conception looked like over time. And the reason I like this is that it's really a great visual for patients to see the fact that fertility declines over time, and that although it is somewhat stable in a woman's 20s and early 30s, we start seeing declines as early as 37 that are significant. I'm going to use throughout this talk a few slides looking at assisted reproductive technology, or IVF outcomes, because IVF outcomes are a great way to just be a surrogate marker for what we see in relationship to age and other factors that are influencing infertility. And in this particular instance, both this slide and the next is looking at just delivery by age. And I think it's important for patients to recognize that to some extent, when you look at the various ages, that when you kind of contemplate women trying to get pregnant in their 40s, you see a significant decline in live birth rates. This is per cycle of IVF, but ultimately is consistent with what our patients are seeing trying to get pregnant spontaneously, which is live birth rates significantly decline as we age. And the highest live birth rates that we recognize both in infertility treatment and in spontaneous conception are in women under the age of 35. Here's another just graphic representation of that, where you see that this is a per cycle element of where for women under 35 going through IVF in the United States, and this represents somewhere in the neighborhood of about 135,000 IVF cycles for this reporting year in 2018. You'll see that if you go through IVF in the United States at this time frame, you had about a 50% chance of a live birth, so past the miscarriage mark, past a termination for an abnormal fetus. And as each age bracket goes, we see that in women over 40, we're often seeing live birth rates that are less than 10%. And if you're 42, it's around 3%. I always say this is the 1-2 punch of aging and fertility, which is miscarriage. And this is something, just as we all know, seeing our patients in the office, a really devastating part of aging and fertility, which is pregnancy loss, which is fairly, again, stable in a woman's, kind of early age group, but as we age becomes quite significant. So when we see miscarriage in women over the age of 40, it's often associated with chromosomal aneuploidy, as it is almost at any age, but certainly more so in these group of women, and is a big counseling point that I talk to patients, especially to set expectations, because for many of our patients, it's hard to see beyond that first initial positive pregnancy test. And we talk about the fact that really, especially in women over 40, kind of step 1 is getting pregnant, step 2 is getting past the miscarriage mark, and step 3 is doing testing to really ensure that the fetus is normal. So let's talk about BMI, something that's been a hot topic really since about 2009, at least in our field, where a lot of research has come forward to look at BMI in relationship to fertility. What we know is the well-described relationship with elevated BMI and PCOS. And so for many of these women, this relationship is described, and we counsel about weight loss, both from the standpoint of fertility with PCOS, as well as decreasing risks of cardiovascular disease and other kind of endocrine-related issues associated with PCOS. But what about women with an elevated BMI who don't have PCOS? So this is being looked at increasingly, and what we see is that we have worse IVF outcomes with obesity independent of an ovulation. We see also increased risks of miscarriage as well. The effects of obesity with a male partner is to some degree less understood. We have seen some studies showing decreased sperm parameters associated with male obesity, and there's a well-known kind of relationship with male obesity and erectile dysfunction. We have seen diminished sperm concentrations in men with obesity, but ultimately it is not confirmed through multiple studies. And then finally, population studies with higher risks of subfertility with elevated male BMI. This is a great study done in collaboration with Boston University and Dr. Lauren Wise, who's an epidemiologist, and Denmark, looking at several thousand couples who were beginning their attempts to conceive, who had no element of infertility, and really just to a large degree were being watched over the first year of attempts at conception. And a multivariate analysis was performed to the degree that they could hold steady every variable, including age, smoking, and so forth, to mine down what the effect of BMI was on spontaneous pregnancies. And I think of all the counseling points regarding BMI in the general OBGYN office, this is one that's really good because this is looking at fecundability or the probability of conception on a month-to-month basis, just looking at BMI. And you can look at this referent group with a BMI of 20 to 24, which is considered to be normal. And if you look, the probability of conception on a monthly basis declines significantly associated with elevated BMI. You know, I have a phenomenon in my office, and you may as well, which is patients coming in with a tremendous effort toward trying to get pregnant based on, for example, different things they're doing, whether it's acupuncture, whether it's removing things like gluten from their diet, certain supplements that they're adding. And I tell them that really there's not a lot of evidence that any of those things may truly improve their chances to conceive. However, if they are obese, without a doubt, if they did nothing else but lose weight, that would improve their chances. It's interesting that people put to some degree such a large effort toward other means, and it speaks to the fact that weight loss is such a difficult problem in medicine and one that we're still really, heavily working on. So I like this forest plot, this big meta-analysis, and we won't spend a lot of time on this, but really this is just a great graphic way to say there is without a doubt a tremendous negative of smoking, in both from the standpoint of fertility and IVF outcomes. And so the overall statistic shows that the odds ratio toward infertility in multivariate analyses show that it's about a 1.6 for infertility, so about a 60% higher risk of infertility in people who smoke. And when you look at IVF outcomes, you're about a 45% less likely chance of conception based on a current smoking history of the female partner. Interestingly, in my state, Massachusetts, there is a mandate to cover infertility. But as you might imagine, all of the major insurers who have seen this very study ultimately have, to a large degree, decided to drug test our patients for cotinine levels. So if you have any history of smoking, you must demonstrate negative cotinine levels prior to your ability to go through IVF, or they won't pay for it. So I think, interestingly, that is on some level certainly improves the overall outcomes from IVF if patients are able to quit smoking. All right, so let's go ahead and move on to the workup and kind of how do you structure that. Well, certainly we start, as we all know, through the history and physical, where we're really focusing on the duration of infertility. And certainly you're going to see some very anxious people who are 32 and have been trying 3 months and are convinced they have an issue. So trying to understand what that looks like, the frequency and timing of intercourse, and again, what are the medical, surgical, and gynecologic historical issues that may be influencing that we talked about in a previous slide. Lifestyle issues, it's a good time to try to really assess tobacco use, what is the change in the weight over a number of years, alcohol and drug use, as well as exercise, diet, and stress levels. From the female standpoint, the ovulatory evaluation, hormonal testing, looking at ovarian reserve, as well as a uterine evaluation, looking at multiple ways to look at the uterus, and we'll talk about that as well. And then from the standpoint of the male factor, the classic of looking at the semen analysis, and if abnormal, going forward with a hormonal evaluation and potentially a urologic eval. Okay, so let's talk about the female overview. When we try to think about if somebody is ovulatory, really historically, if they're having predictable menstrual cycles, whether they're a little bit shorter than average or longer than average, really you can take from that somebody's ovulating. I tell my patients there's not many black and whites in medicine, but one of them is this. If you're having a predictable cycle, generally it's indicative of ovulation. If you want to prove this to yourself and your patient, you can check a mid-luteal progesterone somewhere in the neighborhood of 8 days, 20 to 23 on an average 28-day cycle, and you should see the progesterone level to be greater than 4. Many patients become very involved in doing basal body temperature charts. And interestingly, once you see the biphasic response of one chart, you say, okay, we know you're ovulating. But for many patients, they're doing this routinely, not necessary, but sometimes can provide them some sense of control if they can continue doing these charts. But I usually encourage them to cease and desist on the charts because they're a lot of work for telling us something we already know, which is they're ovulating. And then finally, urinary LH testing. There is just a tremendous market for this. And a number of years ago, there was this kind of product for which women used urinary sticks that really gave you a binary result, yes or no. Those are actually ideal because ultimately what you're really trying to assess for patients is once they're surging so that they can time intercourse. The only real benefit of urinary LH testing for many patients with a regular cycle is just narrowing the window of intercourse. So for many patients who don't find a big benefit in narrowing the window of intercourse, actually I encourage them not to use the urinary LH testing. Finally, ovarian reserve testing, an important component of what we're looking at, and there are multiple ways to look at this. The most common are day 3 FSH and estradiol levels. In our state where we have a mandated insurance coverage, we classically do a clomiphene citrate challenge test, which is looking at estradiol and FSH on day 3, and again on day 10 with intervening Clomid at 100 milligrams, days 5 through 9, kind of just looking at a more comprehensive view of FSH and estradiol level. Antral follicle count through ultrasound, generally done in the early follicular phase, although truly you can do an antral follicle count anytime during the cycle. And finally, anti-Mullerian hormone assays, which we've really probably in the last 10 years used more and more as a way to look at egg reserve. Finally, evaluation of the uterus and tubes, HSG, sonohystogram or hycosi, and hysteroscopy are the classic of what we use frequently. Laparoscopy certainly is used, and oftentimes in a coexisting case where somebody may be having laparoscopy for a large ovarian cyst or pelvic pain, and the uterus and the anatomy of the fallopian tubes can be observed at that point. Hormonal testing, we look a lot of times at thyroid function at this point as it relates to both miscarriage and in pregnancy. Prolactin, we usually confine that to women who are having oligomenorrhea or amenorrhea. And finally, prenatal screen, which really includes all of the typical tests that you might want to look at in a woman conceiving, things like rubella, varicella, and rubeola vaccine status, and are they still immune, CBC, type and screen, that sort of thing. And we'll also talk about genetic screening in the coming slides. All right, so I'm going to give you a case presentation. I've got a few cases that are out of my office, kind of thinking about the real-life patient and how we apply this. So this first case is a 38-year-old who's a G1P0 who's been trying for over a year, and a notable family history of her mother who went through an early menopause. She had a conception in her early 20s that was unplanned, resulting in elective termination. Her initial tests in coming to see me showed a day 3 FSH of 2.1 and a day 3 estradiol of 101. So a great segue into ovarian testing and looking at ovarian reserve. So probably the most classic formulation for which we look at ovarian reserve is day 3 FSH and estradiol level. This has probably been most widely studied of all the tests and is good correlation with fertility treatment and response. It really relates to the follicle cohort size, and this type of testing is readily available. It is not a send-out test, I would say, in most hospitals and most peripheral labs. This is an easily done test. The drawbacks are that when you see the patient in the office, they're not likely to be day 3 of their cycle, so this necessitates an additional visit for this type of testing. It definitely is not accurate in predicting pregnancy, and I'm going to kind of go more into that and prove that to you through a study I'm going to look at a little farther down. And the majority of the data is really looking at IVF outcomes. So this type of testing is at its best helping me decide what type of medication I need to treat this patient and what dosing. So I mentioned earlier that ovarian reserve testing from the standpoint of anti-Mullerian hormone levels in the last 10 years have been used more and more for doctors like me, and there are some real benefits, and we'll talk about that. But first, what is AMH? So this is a look at the hypothalamic pituitary axis along with the ovary. And what you see here is a pool of follicles, the small antral follicles and preantral and primary follicles that secrete a small peptide hormone, which is the anti-Mullerian hormone. So it's a little hormonal ping, if you will, looking at the follicular burden in the ovary. How many eggs do I have left? And I'm big when I'm counseling patients on analogies, and I talk about the old-fashioned dipstick, looking at the engine and the quarts of oil, and I say this is kind of our look at what the what the remaining follicular pool is. So when we think about AMH, we look at women who have kind of poor reserve versus borderline versus reassuring. And so we think about an AMH of 1 being the lowest level of normal that would be in a reproductive age woman. So when we see an AMH of less than 1, we consider that to be poor reserve. Around 1 to 1.5, perhaps borderline. And for women who are greater than 2, we would consider that reassuring. How about antral follicle count? This is a great way to look at follicular burden and ovarian reserve as well, but also has the downside of being an extra, potentially an extra visit to the office, as well as there are some operator-dependent aspects to the count and how good the person is at ultrasound who's doing it. As a reminder with AMH, it is cycle independent. So if you're seeing someone in the office for infertility, you can actually send them for blood work that very day to look at an antral follicle count. It does not matter. The only influence that I see on AMH is being on the birth control pill. So for anybody who's on the long-term use of the birth control pill, I typically try to take them off for at least a month before I check their AMH, because we can see some suppression in that regard. So for the ultrasound exam, usually we're looking at this in the early follicular phase, but as I mentioned, you can really do it throughout the cycle. You're hoping to see a typical minimum of 3 follicles per side. It can be a good predictor of ovarian response and may be helpful in diagnosis of PCOS for some women. And here I have a graphic representation of kind of an average antral follicle count that you might see, where you are in the office going through the ovary from one pole to the next, counting the small follicles, of which you're hoping to see at least 3 on each side. Here is a good representation of a woman with polycystic ovarian syndrome, showing the classic kind of string of pearls, where she has a larger ovary, lots of stroma, rimmed with small follicles. Other tests for ovarian reserve, we mentioned clomidine challenge test, which in our state we do typically in women over 40, but this is again looking at day 3 and day 10 FSH, of which you're hoping to see an FSH of under 10. Somewhere between 10 and 15 would be considered to be borderline, and for women, especially in women over the age of 40, with an FSH of over 15, either on day 3 or day 10, this would be considered diminished ovarian reserve. Finally, serum inhibin B assays are not widely used associated with the reliability of the assay. This is, of all the slides, one of my favorites because it really talks about something that I think impacts the generalist in their office, which is the average woman coming in to ask, can you do blood tests on me to tell me if I'm going to be able to get pregnant? And am I going to be able to get pregnant in a year or 2 years? So Steiner in 2017 did a great study where they looked at 750 women who had not been trying to conceive for any time more than 3 months, and they measured ovarian reserve looking at multiple different means and really just watched them for a period of 12 months, trying to understand if we could predict who was going to get pregnant by their measures of ovarian reserve. The statistics were adjusted for BMI, race, smoking, all of that. So we really could try to look at just the predictors of ovarian reserve. And they looked at AMH, FSH, and inhibin B, and they looked at pregnancy at both 6 and 12 months. So I'm going to call your attention in this slide to just these 2 groups. So this was the group of women who had the AMH testing and the day 3 FSH testing. So you can see how the group broke down. The 84 women had an AMH of less than 0.7. 579 had what would be considered a more normal AMH of between 0.7 and 8.4. And then there was the group of women that had an elevated AMH. And what you see here are their pregnancy rates at 6 months, which were 65, 62, and 59. And at 12 months, 84, 75, and 66. No statistical difference between the women who had a poor AMH and the women who had an elevated AMH. And the same is true for women with FSHs of less than 10 and women with FSHs of greater than 10. So here we saw the pregnancy rates at 62 and 63 at 6 months and 75 5 and 82 at 12 months. So why do I think this is an important study? It tells us in counseling our patients that there is no screening test for infertility. I wish there were, but we don't have one, because I tell my patients I have a room full of people waiting to see me for infertility that have a great AMH, and there are plenty of women in the community with poor AMHs who are perfectly fertile. So this is not a screening test for infertility. And I think my biggest concern would be that if a woman had these tests done and noted that she had a good AMH and she's 37 years old, she may carry away from that she'll be perfectly fertile into her 40s, and that may or may not be the case. So I think the counseling about age, about lifestyle issues is really much more important than doing this type of testing. I reserve this type of testing for women who are either infertile or are considering fertility preservation. So this is an appropriate test for women who are considering freezing their eggs, but I counsel them to not be falsely reassured by very good numbers or falsely panicked by poor numbers. They really don't indicate that. And I certainly see that in real life all of the time when I have patients who come to see me for egg freezing, and ultimately we see that they are able to conceive even with a poor AMH in the future. All right, so let's talk a little bit about elective fertility preservation. And again, one of my colleagues is going to talk about this in greater detail in her talk. But this is something that I think we are certainly seeing in our office more and more, and I imagine that the OBGYNs across the country are getting this quite a bit as well. So again, markers of ovarian reserve are not helpful to predict fertility, and they're most useful to determine medication dosing for IVF. I also use them to predict if you were to freeze eggs, this is what I would predict that we should reliably think that we'll get, and then we can then look at a mathematical algorithm to determine what the live birth rate would be looking at this predicted number of eggs they get. The general counseling for egg freezing is that it's now widely available and generally is about $5,000 to $7,000 per cycle. That generally does not include the medication associated with the cycle. Thus, that is variable according to how much the patient will need. I think it's important to note that for women with severe diminished ovarian reserve, the medication can be $10,000 to $15,000 additionally if that is their decision to move forward with egg freezing. The yearly storage fees for most programs, as well as long-term facilities that store eggs and sperm, is anywhere from $200 to $500 per year. And finally, if there is a concern about future fertility, or if this is somebody who's really looking to understand kind of what they need to know about future fertility and the possibility of fertility preservation, I really recommend a reproductive endocrine consult. I see these patients frequently, and I tell them what's important is not if you're freezing eggs or not, but that you're becoming educated about it, because it's a deeply personal decision. But the more a woman can come to this with information, the better the decision. Okay, hormonal testing and prenatal screening. Thyroid, I'm kind of smiling at Dr. Hornstein because our group is really always looking at TSH numbers and kind of how we treat that and what the optimal normal is. And the reason it's an ongoing dialogue is there are multiple studies and there's no complete consensus between the American Society of Reproductive Medicine, ACOG, and other groups. What we try to do is optimize normal TSH levels to be less than 3. There is a question of a relationship to first trimester loss with elevated TSH and TPO antibodies. And I think still we are waiting to get a final understanding of how to manage this perfectly. But in general, testing your patient's TSH prior to conception is an important part of this. Prolactin, we generally can find that as testing in women who either have galactorrhea or other symptoms or amenorrhea or oligomenorrhea. For a normally ovulating woman with no other symptoms, I generally try not to check prolactin. And in final prenatal screening, we talked about things like varicella, rubella, immunity, CBC, type and screen, but really the big new, I think, focus on prenatal screening is expanded carrier panel screening. And this is really a complicated issue, but one that I think if you have a captive audience of somebody who is coming to you prenatally is very important. So there are a number of companies in the market who now offer an expanded prenatal screening genetically looking at autosomal recessive disease traits as well as some X-linked traits such as Fragile X for which you would screen the female partner. If the female partner has any of these traits that are positive that are autosomal recessive, then you would screen the male partner. The obvious idea here is that we're hoping to prevent disease for people who have no knowledge that they're carrying an autosomal recessive trait for cystic fibrosis or spinal muscular atrophy or polycystic kidney disease. I think the tricky thing is that some of these panels are expanding to such a degree that there's such a high likelihood that something will be positive. The current panel we use at Brigham and Women's is approximately 176 conditions, but I've seen them up to 500 conditions at this point. In general, if there are any questions genetically that a patient has regarding their family history, we widely, early and often send for genetic counseling for patients that have a family history of autism, developmental delays, any kind of ill-defined types of issues, I think is really beyond certainly my capabilities as a reproductive endocrinologist to truly adequately counsel them. So I will send them directly to genetic counseling, and they will order the testing and really give them authoritative counseling. I will point out that for patients that have a compelling family history of cancer, these expanded carrier panels do not include this. And so ultimately, I send them to a very specific genetic counseling through a cancer center that can talk to them about the different screening elements for that. But that would not be included on any element of the general expanded carrier panel. All right, my next case presentation was a patient I had who was a 27-year-old who had a live birth, who had a miscarriage, but ultimately had, despite the fact that she'd been able to conceive both of these pregnancies within 2 months of trying, ultimately had not had any luck in trying since her D&E. She had also noted that her monthly menstrual flow had decreased dramatically since the D&E. And when I did her HSG, this is what I saw, and this is really consistent with somebody who has Asherman syndrome. She really had an obliterated cornu on the left side, consistent with kind of widespread adhesions throughout the cavity, and these were repaired. She ultimately was able to conceive after operative hysteroscopy over several actually surgeries due to some of the reoccurrence of her adhesions. But this is an example of a uterine evaluation that's fairly typical in our group, which is using HSG. Some of the benefits are good specificity. It's very good for identifying distal tubal adhesions. There is some demonstrated effect on studies looking at the oil-soluble media associated with this test. The drawbacks are it's not always a reliable diagnosis of peritubal adhesions. We see a fair number of patients with a false positive rate for proximal occlusion. They are immediately assuming this means their tube is blocked, but what we know is that spasm can be an issue. And it is typically an uncomfortable test for most. We are using a lot of hycosi or sonohysterography today based on many different things. And this is just a picture one of our radiologists sent me of a good cavity filling polyp that you can see very well on this kind of study. But basically, we look at 3D images of hycosi where we're able to fairly reliably see any pathology within the uterine cavity, whether it's submucous fibroids, adhesions, polyps, as well as a fairly reliable way to look at the fallopian tubes using agitated saline, for which we can track the bubbles coming out of the fallopian tubes. And then the added benefit of being able to look at the ovaries, at which time an antral follicle count is performed, as well as looking for pathology. We've all had the situation where we performed an HSG on our patient, which showed the cavity appeared to be normal and the tubes were open, and finding out in a treatment cycle that, by the way, they have a 10-centimeter fibroid that's intramural that did not involve the cavity that we never saw on HSG. So I think looking at ovarian and uterine pathology is another great advantage of doing the hycosi as well as antral follicle counts. Tests of limited utility, I'm not going to spend a lot of time on this, but postcoital test I think really has been abandoned by most. It really has no understanding of the results as related to pregnancy rates. Endometrial biopsy is not something that's considered to be a baseline test for infertility. We really want to consider it when we have uterine pathology that's strongly suspected, and we no longer use it just routinely for histologic dating because this can be of unclear benefit for many couples. Basal body temperature charts, we talked about the fact that if you want to demonstrate that biphasic classic appearance to prove that you're ovulating is a fine way to go, but in fact doing repeated basal body temperatures on somebody who's normally ovulating is probably of limited benefit. Mycoplasma cultures, this is a little controversial, and there's certainly groups of reproductive endocrinologists that still use this test widely, but I'd say overall it's not routinely done. as well as immune screening, including antiphospholipid antibody tests just for infertile people. We know that there's an element that we look at for recurrent miscarriage. Anti-sperm antibodies, ANA, that sort of thing is not something we do routinely. Karyotype, we really don't do this as a starting test. We do it in women with recurrent loss as well as men with severe oligospermia, and we would add to that in couples that have repeated treatment failures. We will frequently look at a karyotype on both. Finally, last case is a 32-year-old who has had 1 year of primary infertility and ovarian reserve testing and an HSG with her OBGYN was noted to be normal. Her husband's a 37-year-old with no history of any concerns, no previous paternity, and no medical issues. However, his initial semen analysis noted azospermia. So the male overview, semen analysis, the absolute, kind of first line look at how male fertility is assessed. And generally what we say is if it's abnormal, we would recommend repeating it in 1 month. One test never tells the whole story. And if the man has had any, kind of proximal medical issues, illness, that sort of thing, you can see a dramatically different test in 1 month. The prenatal testing and genetics screen when indicated. For example, in this case where the man is azospermic, we would consider a karyotype. We would test him for cystic fibrosis, and we would do a full hormonal panel, things like total and free testosterone, FSH, and TSH, CBC, and prolactin. Urologist referral, we refer early and often for men with abnormal semen analyses where they undergo a physical exam, oftentimes a scrotal ultrasound looking for things like a varicocele or a dilated vein that may be impacting their outcomes, as well as an endocrine evaluation. The semen analysis, we're looking for a volume between 2 and 5 cc's, a concentration of 20 million at a minimum, and a motility of 40%. We look at a total modal count to really kind of judge how this is going by multiplying volume by concentration and motility, and ideally we'd like to see a total modal count in a fertile man to be 10 million or higher. Finally, we refer with abnormal semen analyses with repeat. Any element of erectile dysfunction, very important to ask all of your couples who may be reticent to admit that or put that on a screening questionnaire, but in fact that can be the source of some infertility. Any high-risk medical history, like a history of orchitis, environmental or drug exposures, or a history of infertility in a previous relationship. Finally, genetic testing we talked about, especially in the setting of severe oligospermia, defined as 5 million or less, a karyotype, and we also do SRY deletion testing in men with azospermia. The SRY region of the Y chromosome can confer kind of the knowledge of whether this man is sterile or not, and is an important part of that workup. So in summary, how we are evaluating patients according to criteria, and we avoid unnecessary testing. We counsel patients to improve natural fertility and modify lifestyle issues. The basic evaluation that we use looks at both the uterine anatomy and the fallopian tube anatomy, ovarian reserve testing, and any additional workup is indicated by history and physical, as well as just as a kind of reminder that this is a captive audience, so it's a great time to do genetic testing prior to someone conceiving so that we can know that group that may carry a genetic issue that could impact the health of the fetus. Basic male evaluation, again, a semen analysis. If the first one is abnormal, absolutely repeat the second, approximately a month later, ideally. Always ask about sexual functioning. I think that's an important part of that. Urologic evaluation and referral for any abnormalities associated with the sperm or men's sexual health, including the erectile dysfunction. And I generally don't order the scrotal ultrasound myself. I generally let our urologist determine if they think that's necessary, and it's usually based on their physical findings. So thank you very much. This is my beautiful family, and I'm going to turn it back over to my colleague, Mark Hornstein. Thank you.
Thank you, Rachel. That was a spectacular introduction to the beginning of our course. This year, the format will be to save our questions for the panel discussion, which will be at the end of the morning session. I'll hold those. I see a number of really good questions coming across my screen. Next, I would like to pause just for a moment. We'll reset, and then I'll have the opportunity to introduce Dr. Elizabeth Ginsburg to you.